Friends, I think we have had a busy morning, and Vandana just told us how to make money out of refractive practice. Now maybe I'll give you some tips on how exactly to do it. So my topic is pearls and pitfalls in smile. We have been doing for about the last four and a half years, done about 4,000 eyes. Many of the videos that I show here are the ones which we experienced in our initial days. Once you get reasonable experience, it becomes second nature. You may not come across these problems. I think what we have here is a mix of early adapters, experienced surgeons, and some who are intending to go into adapting smile. Maybe they'll find it useful. One of the things that is challenging is to make sure that you are in the right plane as far as dissection is concerned. So you have to go in front of the lenticule and behind the lenticule. And for this, I do this initial dissection with so the initial dissection, it goes in front over here. And what you see in this arrow is that demarcation line. And then the second dissection happens over here. So you can see here. And what I call the stop sign, these two cannot be continuous. If it cannot go right across, you see this small area which sort of limits the passage of this dissection to going on to this. So that's because the first one has happened in front and the other one has happened behind. So if this kind of a stop that I experience, that I can't go right across, that tells me my initial dissection has been in the right place. And after this sharp instrument dissection, if you introduce a spatula, I can go ahead and complete the procedure. The other sign that I used to look for in my early days was what I call the silver streak. In your smile machine, you have the ability to increase the magnification. We usually do not do this in this using the higher magnification. So in the initial stage, you are going in front of the lenticule. In the second stage, you're going behind. So when you go behind, the edge of the lenticule acts like a silver streak, and especially under higher magnification, you are able to see that. That's another tip that tells you that you are in the right plane and you can proceed with your dissection. This is happening in front of the smile lenticule, and here basically the edge of the lenticule is hidden by the sharp instrument, while when I go behind, it may not be very obvious in this video. The quality of video that's coming up here is not so great, but you can make out there's a silver line over there which is in front of this instrument, and that immediately tells me that I'm in the right plane and I can go ahead with the further dissection. So when it comes to my initial dissection, these are the two aspects that I look for. That is a stop sign where my dissection doesn't go right across, and then a small silver streak that's in front when I'm doing the dissection behind. So laser gets disrupted. Initially we used to try to dry up the whole conjunctival sac because we are taught that you may lose suction if there's excessive fluid. But you also realize that if you have any kind of debris, if you have a certain amount of even fluid on the surface of the cornea, then you could have the laser light not passing through. These dark patches that you see over here are essentially nothing but where the laser light has not gone through, because of which the dissection has not taken place. And as you would see in the subsequent dissection, because you have to use excessive force to go through the areas where the laser light has not passed through. It is doable, but obviously these are the cases where there would be some significant inflammation, certain amount of haze in the interface, and also the recovery time might be a little longer. So it's important that you neither have an extremely dry conjunctival sac, nor do you have a moist conjunctival sac. So this is essentially what we adapt. That is, what we want is a moist corneal surface, but not a wet surface. And we want a dry conjunctival sac as such. So just before the docking takes place and comes in contact with the corneal surface, as the instrument goes down, my nurse flushes the conjunctival sac. The optometrist puts a drop of xylocaine. Only one drop has been put in the conjunctival sac before the speculum has been placed. This is the second drop. And what you see is I do not place my on the cornea, but in the conjunctival sac, because I don't want excessive fluid in the furnaces, but I want my cornea to be a little moist. And that placement of the Vexel sponge right at the limbus also absorbs whatever excessive moisture is there on the cornea. And I make sure naturally there are no debris, no fibers on the corneal surface. Once you have that, the incidence of the dark spots that you saw earlier significantly comes down, and you seem to be in better control of the surgery as such. And again, this is something I'm sure all smile surgeons are doing. Irrespective of the number of cases that you have done or the number of eyes, the ease with which the lenticule seems to come out, it's always important to spread the lenticule on the corneal surface and make sure it's complete. I thought I had done a reasonably good job, but then you will find that almost 3 clock hours of tissue is missing. And fortunately for us, it's extremely easy to identify the silver of tissue that's left behind. Sometimes you can use the slit lamp, but even most often I find that's not necessary. What was left over there was almost from 5 o'clock to 7 o'clock. I do a little more dissection over there, and you see that I bring that out and spread it onto the corneal surface. Obviously, if I had left this behind, maybe the refractive correction initially would have been all right, but this would have led on to a significant amount of irregular astigmatism and an unhappy patient. So even though we have done quite a lot of these procedures, even today, I regularly ensure that however easy the lenticule separation has been, to go ahead and place it on the corneal surface and make sure that I have it complete. Among all the femtosecond laser platforms that I've used either for cataract or for laser refractive surgery, I think the Visumax is the one which has the softest docking. It has a great advantage in the sense that the patient continues to see the green light all the time and never loses vision. There's no subconjunctival hemorrhages. It's a corneal section. It's a curved interface that you have. But at the same time, it also translates the fact that it is easy to lose suction. And you would not see me activating the suction in this. The moment I see bubbles like this, that tells me that sometimes you've got a nice centered dog, the green light is right on the center of the pupil. You think that after all it's 30 seconds, let me go ahead. Sometimes even much less than what you see over here is always a good idea to abort the procedure, because most often these are the cases when you see those bubbles over there where you would end up with an inappropriate and a cut, and you might lose suction on the way. So extremely important that in these cases you abort, lift it up, and then dry up the conjunctival sac and go ahead with the procedure. We also used to use a small paper to dry up on the undersurface of the patient interface. But now we find that it often leaves behind a certain amount of striations and irregularity. So even though I might see a droplet at the bottom, if it's too much of moisture, obviously it's important to dry it up. But otherwise there's just a drop over there. I go ahead and still proceed with the docking, because what I find is once it comes on contact with the corneal surface, that just dissipates and doesn't really interfere with the treatment. So what's Pearl 7 is adequate incision. You know, we have this hangover from cataract surgery. You will see this surgery being performed through a 2 millimeter incision, basically just showing off. And it is possible, but it's not necessary. So we have always been told smaller the better, 2.2, 1.8 for cataract incisions. Here really you don't have any big advantage, no great astigmatic outcome, greater biomechanical stability or anything, just because you have a smaller incision. When we started off, it was initially with 4 millimeter incisions. Heard in a couple of conferences that the big guys do it through 2 millimeters. Tried it, it was possible. But sometimes when you have a problem, you have a small lenticule left over, you have a difficult dissection, then it becomes problematic. So as you can see here, doing through a 2 millimeter incision is possible, but today we stick on to a 3 millimeter incision routinely, and I think it works very well for us without any negative impact. This was again in early days when one of my associate surgeons had done the surgery, and somehow the lenticule could not be removed, even though the laser passage had been quite adequate. I was traveling and came back about 4 days later, and this surgery is being done a week later. So you have to, if you have a problem like this, it's a good idea to review the laser passage, and if you think that it's quite adequate, you can see that incision being opened up. It's a little too dark over there. I can see it much better here. And a week after the initial surgery, and that's the spatula being passed in front of the lenticule, then I go behind it, and once the lenticule, the laser passage has been quite adequate, irrespective of the time period after which you go back, you are able to remove the lenticule. Having said that, we have also had a couple of instances where in spite of a second trial, we have not been able to remove a lenticule. And if it's too difficult, don't traumatize the cornea excessively. It's best to leave it alone and maybe do a surface, especially if it's not a high level of refractive error. After a couple of weeks or a month, go ahead and do the surface ablation, which also works quite well. But if your laser passage has been quite adequate with reasonable experience, you can almost always remove the lenticule. And as far as activating suction is concerned, I said the suction is quite low, but we do not want excessive pressure on the corneal surface, and that causes corneal folds, inappropriate laser application. So it's important that when you see the meniscus forming, once 80% of the meniscus is formed, then you press on the foot pedal and activate suction. So that's when you get a extremely controlled procedure. There's no disruption of laser, and you find that the black spots are just not there, and you can get a reasonably good and controlled procedure. And the point, maybe that's not very clear on the video, what I want to drive home is that when you are active, the contact lenses come in contact with the corneal surface. When the meniscus is forming, don't wait for it to go right up to the limbus, but when you see that almost 80% of the meniscus is formed, go ahead and activate suction, and you will find that it's more gentle. You do come across situations, these are two eyes of the same patient on the same day, where you have small corneal opacity, nebular corneal opacities. Many of these patients have been wearing contact lenses. They could be SPK because of a past viral keratitis, viral conjunctivitis. These are not really contraindications. As I will show you can see the two eyes being done. There is a definite nebular corneal opacity in this. I'll show this to you shortly. And I do not know whether you are able to make this out here. It's here and it's here. And in spite of this, there has been adequate laser passage. And it becomes more obvious when you see it the first day post-operative picture. You can see it here. This nebular corneal opacity and nebular corneal opacity over here. Sometimes you are worried that this might not allow laser passage, and you may have difficulty. Obviously, this is a stop as far as laser passage is concerned, but as far as it's not a macular grade corneal opacity, but just a few distributed nebular opacities like this, and there's no activity, maybe you do well to go ahead and perform the procedure. There is no active eye tracking that's available with the Visumax. There's no infrared tracking. What essentially happens is autocentration, where the patient is asked to look at the green light. To my mind, there is a great advantage, because when we center it on the center of the pupil, because of angle kappa, there might be a little decentration of the treatment. But here, basically, your treatment is centered on the visual axis of the patient, because the patient is looking at the blinking green light. When that happens, and sometimes that's the reason that you might find that in spite of an excellent docking, the procedure going well, you do not, it does not exactly correspond to the center of the pupil. In these instances, you can still go ahead, because this might be because of a significant kappa angle. And what you want is centration of the treatment on the centration of the lenticule on the visual axis, and that is something that's possible. So always whenever there's a difference between where the green light is showing up and the center of the pupil, do not think this is decentered docking, and you have to do some kind of a correction. What about enhancement after smile? Residual errors after smile does happen, and though the incidence is not too high, and I think Gitansha in the afternoon will be talking about the Circle software, but it's not free, and that comes at a cost. What we have found is doing a PRK on the cap itself works quite well. The procedure is almost exactly the same as what we do after microkeratoma femtosecond laser, and you can see this PRK being done about 6 months after the initial treatment, where we just do a laser to take off the epithelium. It's a transepithelium PTK that's done, and then subsequently the laser treatment is done. And irrespective of the amount of refractive error that is treated, whenever we do a PRK, we place mitomycin C 0.02% for a period of 30 seconds. It works very well. So obviously, and also to my mind, I have not created a cap. I have not converted the cap into a flap, and the integrity of the cornea is still maintained because it's a surface procedure. Of course, there's a certain amount of irritation and discomfort that the patient has to put up with, but that's something they do accept once you explain to them significantly. As far as laser energy itself is concerned, what this shows is 38. This is what we were using earlier. Basically, the amount of energy that's actually going in is 38 into 5, which is about 150, 190 nanojoules of energy that was being used when we initially got the machine about 5 years back, 4 years back. And now what we have done is to slowly drop it down to 31. That is about 155 nanojoules. Obviously, the lesser the energy that you use, the softer the treatment. There are surgeons who claim, the company also says that you can even come down to 28 nanojoules. But this is all dependent upon the conditions of your individual operation theater and comfort level. There are no prices for saying that I use less and less energy. Whatever you are comfortable with, in our hands we find that coming down from 38 to 31 has helped us. And whenever you are using excessively low energy, you get more of dark spots. And when you use excessive energy, then you get OBL. So basically, you have to find these problems occurring repeatedly. That's when you go ahead and have a look at your energy requirements and tweak it. And one very important thing is, once you have docked, when you are hitting the foot pedal, take your hands off the patient's head or the machine. There's no need to hold the patient's head, because there's an inherent mechanism that's called the closed loop system. There's a feedback from the patient's head, from the interface to the machine, so that the docking, the pressure that's maintained is quite normal. Once you're holding the pressure of patient's head and shifting, then that mechanism doesn't work appropriately. So it's important that you take your hands off during the treatment, and the machine will take care that the appropriate pressure is what is maintained. Last of my section of my slide, the Pearl 15 is, when you lose suction, what exactly do you do? Very simply put, this is the algorithm you follow. If it's less than 10% of the cap of the lenticule cut that has happened, there's no change that you need to do. Just redock and go ahead with the procedure. If it's 10% to 100% of the lenticule cut, then you have to convert into a flap procedure. Convert your cap into a flap, and that's possible with the same interface. If you have got the side cut of the lenticule made, or the lenticule is partially cut, or you have the last cut, the fourth step coming up, and that's the time when you lose suction, then you can go ahead with SMILE. Mind you, you need not change the interface. You might have to, as you can see over here, some tweaking of the adjustments. It's very easy to understand this. You just have to, the instrument itself guides you to go ahead and do this procedure. It's extreme. You can very well complete the procedure with optimal outcome. And as far as, let me just show you a couple of examples. I think this is suction loss at lenticule cut, where you could see the suction loss occurring. And basically what I have done is to convert it to a flap and gone ahead with the procedure. Less than 10% suction, just redo. More than 10% suction, then you have no other choice but to convert it into a femtolastic procedure. And in case it happens after suction loss, after side cut, or at the time of the flap making, then as I said, you just have to drop down the diameter by about 0.2 millimeters and go ahead and use the same patient interface. Make sure that you are able to identify the center of the pupil and do the treatment and complete the treatment. And usually there is no compromise in the ultimate outcome. And this video, I think, Rohit, I would like you to watch this. I mean, some interesting thing happened. It hardly a couple of weeks back, where actually the patient's eye moved, and suction was still on, and the laser continued to fire. You can see this carousel coming in from in, and the initial lenticule cut happening, and subsequently the side cut of the lenticule and the flap cut. You see the patient's eye has significantly moved. I had not taken my, but the suction was still maintained. And you can see that it's a fairly decentered ablation that has occurred as far as the lenticule cut is, as far as the cap cut is concerned. And it stopped because I took my foot off the pedal. So I was in a dilemma as to what exactly I should be doing. I'll let you know what I did finally, but maybe some inputs from the audience would be worthwhile. Thank you so much for your attention.
Excellent, Dr. Ramamurthy. It was really great, and such a pearls are very important today's time because smile is still new procedure. So thanks a lot. We have something like a game of thrones.
Can I have an idea about, because the last case I showed, I mean, where the laser continued to fire, but it was decentered. A few cases where I had suction loss, always the laser just stops and the eye just moves away. This was one case where the suction continued, and only thing is I noticed that there was significant movement and the laser was firing inferiorly. So
I'm not sure, but most probably it looks like that machine did not know that complete suction loss is there. So machine still...
No, basically it continued to fire because suction loss had not occurred.
Correct.
This was one of the...
Correct.
And,
so patient just moved, but the cup was still
yeah,
there.
it was still holding on.
Yeah. So that's the reason I think most probably it was there.
Any suggestions? Yeah, please.
I read it in Dr. Dan Reinstein's book that there is something called as surgeon-induced suction loss. It means the surgeon
I'm at fault, I agree.
So I don't know whether the Zeiss, the Visumax allows you to start from the lenticular cut, because if you dock it again and start from the lenticular cut, then I think we can go ahead with the procedure.
Actually, this is exactly what I did. I spent a few minutes thinking as to how should I handle this. Then I decided that maybe a certain amount of laser passage has occurred. What if one more passage of laser, why will there be a problem? And I just redocked just like you would do if in case you have lost suction during lenticule, and then went ahead with and completed the procedure. The machine allowed me to do that also. But what I found was that the initial incision I could open up, but then the passage, the instrument was a little tough. And I just decided to abort. I thought, let me not mess around with this. Just treated the other eye. And then it's, as I said, it's just a couple of weeks since it's been done. The cornea is clear and the patient is now having the same refractive error. At the end of 1 month, I plan to do the procedure. What procedure? Yes, Rohit?
Do you think that when you're operating, when you have that amount of opaque bulbal layer, do you think we should, if there's too much of OBL, do you think we should stop? We should do it at a little later time when there is less of those OBL? Because if the OBL is there, the laser delivery itself to that place would be totally different.
I think it's a very good point. I mean, laser reaching there is one problem. The other point is, what about the center of the pupil? Identification of that itself becomes too much of a problem when you redock. But what I find is that by the time this thing happens in about 5 minutes or so, it at least thins out. And if just in case you opened up the incision, much of the gas bubbles escape and we go ahead and redock and do it. But maybe waiting for some more time for those bubbles to disappear would be a good idea.
Because one of the traditional teaching here is when there is a suction loss and you redock immediately and start the procedure. Many times the patient loses suction is always, from the start itself, he's moving his eyes, and the laser delivery is always little haphazard. There's a lot of OBL spill all over. So when you redock in these patients, some amount of laser spots will never reach the same place as where you want. So that's why sometimes, when you have too much of an OBL and then suction loss, is it necessary that we should do it at the same time, or we just continue after the OBL goes? Because OBL is a major factor for an uneven, different planar, cuts there.
Theoretically, I think it makes sense, but practically when we have continued, it has worked. I mean, how do you deal with this last case? I mean, I still have to decide, what do I offer him? Do I go ahead with a second smile procedure or a femtoLASIK, or do a surface procedure? So because there is some amount of dissection that has taken place.
Sir, it depends on your topography. How does your topography look? But looking at that, it's not in your visual plane. It's inferior. So does your topography looks similar to what it was preoperatively?
Frankly, 2 weeks out, we just checked the refractive error and looked at him with the slit lamp. We don't plan to do it up to 1 month. It's just about a couple of weeks. Maybe I have not yet checked the topography.
But the question is, sir, because if it's not in your pupillary plane, which I don't think it is.
No, it's sort of moved down.
It's moved inferiorly. will it make a difference to you? Will that small area make a difference to you?
No, my greater concern, yeah, maybe we can get away with it, but my greater concern, some amount of cleavage would have happened, though I have not opened up the incisions and passed the instrument. When I found resistance, I aborted. But are we okay to go ahead and repeat a smile procedure? Maybe if I had used a 110 flap cap, I just put back 110 microns. But we may not be exactly in the same plane. Will I end up getting two different planes and making dissection a little messy?
Have you done OCT?
But the
of-
best safe.
Sorry? The lenticule cut was complete. I lost suction during the flap cut when the... That's right. Can you use the mic?
Till he gets the mic, sir, why don't you do a circle and make a flap?
That's a good idea.
And with
that's a-
OCT, have you done OCT, like if both the lenticular passes are same, or if there is some, irregularity?
Irregularity.
Both of them are together, there can be some irregularity in between the two.
No, frankly, I want to just wait for maybe next time I'll get back to you. No, I know you can talk loudly. Go ahead.
Okay, you made both the cuts. You had some resistance. Now, I would suggest taking this patient into a surgical microscope, not the smile microscope, and try to look at this and try to do the dissection. I suppose you'll be able to do that because the cut has already been made. There's no problem. The area we are bothered about is inferior, where there could be a double cut. I don't think that's going to interfere with the issue at all, because you're going in the right plane from the top, and then you'll stay in the right plane right through. So I don't think...
I think different
you should
ideas,
try
but
to go
frankly,
under the
a
surgical
patient has
microscope.
about 3.5 diopters. What my plan is to just wait for a period of 1 month and do a surface ablation, not get into the cornea at all.
Thank you, sir.